Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article 7-Year Follow-up Assessment of Cardiac Function in NSABP B-31, a randomized trial comparing doxorubicin and cyclophosphamide followed by paclitaxel, ACP, with ACP plus Trastuzumab as adjuvant therapy for patients with node-positive human epidermal growth factor receptor 2 positive breast cancer by Edward Ramond et al. My name is Nancy Lynn, and I'm a medical oncologist and assistant professor of medicine at Dana-Farber Brigham Women's Cancer Center in Boston, Massachusetts, USA. My oncologic specialty is breast cancer medical oncology. Long-term follow-up of NSABP B-31. How well can we predict cardiac toxicity with Trastuzumab? The physician must be able to tell the antecedents, know the present, and foretell the future, must mediate these things, and have two special objects in view, to do good or to do no harm. The art consists in three things: the disease, the patient, and the physician. Hippocrates from Of the Epidemics, Book 1, as translated by Francis Adams. The introduction of adjuvant Trastuzumab has dramatically reduced recurrence rates and improved survival among women with stage 1, 2, and 3 human epidermal growth factor receptor 2, HER2-positive breast cancer. Although the majority of trials have evaluated the use of Trastuzumab given sequentially after an anthracycline-based regimen, other regimens have also been evaluated, including the TCH regimen of docetaxel, carboplatin, and Trastuzumab. The motivation for testing a non-anthracycline-based regimen was based largely on concerns about both short- and long-term cardiotoxicity. Indeed, in the pivotal trial conducted in the first-line metastatic setting, 27% of patients receiving concurrent doxorubicin, cyclophosphamide, and Trastuzumab developed either symptomatic or asymptomatic cardiac dysfunction, compared to 13% of patients who received paclitaxel with Trastuzumab. Fortunately, rates of early cardiac dysfunction in the large adjuvant Trastuzumab trials have been substantially lower than might have been predicted from the metastatic data. In the HERA study, which evaluated a sequential regimen of Trastuzumab monotherapy following completion of chemotherapy, the rate of severe congestive heart failure was 0.8%, and 3.6% of individuals experienced a significant decrease in left ventricular ejection fraction at 3.6 years median follow-up. In the N9831 study, among patients who received doxorubicin and cyclophosphamide followed by concurrent Trastuzumab paclitaxel, ACTH, the cumulative incidence of cardiac events was 3.3% at 3 years. In two phase 2 trials exploring dose-dense AC preceding Trastuzumab-based regimens, the rates of cardiac toxicity were also low at short-term follow-up. However, there remain valid concerns about the impact of Trastuzumab on longer-term cardiac outcomes. As highlighted in a recent editorial, the long-term sequelae of Trastuzumab-associated CHF and the clinical meaning of the asymptomatic drops in LVEF are still incompletely characterized. If the superiority of TCH over ACTH were unquestioned, then there would be little debate. However, the BCIRG-006 trial was neither designed nor adequately powered to directly compare these two regimens, and the 3% absolute difference in disease-free survival favoring ACTH raises the possibility that the two regimens may not have equivalent efficacy. Given these issues, how can oncologists provide the most balanced recommendations, and how can patients make the most informed decisions, taking into account both efficacy and toxicity on an individual patient-by-patient basis? While the role of anthracyclines in the treatment of HER2-positive breast cancer continues to be debated, rightly or wrongly, clinicians and patients are voting with their feet. Nationally, the use of anthracycline-based Trastuzumab regimens has declined precipitously in recent years. In 2008, among the Medicare population, taxane-based Trastuzumab regimens were administered 5 times more frequently than anthracycline-based regimens. even among patients less than 65 in an insurance claims database, of which 64% were under the age of 55, taxane-based trastuzumab regimens were employed approximately twice as often as anthracycline-based regimens. This is from Sharon-Giordano, Personal Communication, June 2012. Although we are not aware of large-scale studies examining the factors underlying this shift, it is reasonable to postulate that concerns about toxicity, and in particular cardiac toxicity, are likely a major driver. In this issue of Journal of Clinical Oncology, Ramond and colleagues present 7-year follow-up of cardiac function on the NSABP B-31 clinical trial. The trial randomized patients with node-positive, HER2-positive primary breast cancer to receive either anthracycline and taxane-based chemotherapy alone or with trastuzumab, with the trastuzumab initiated concurrently with commencement of the taxane. A cardiac event was defined as cardiac death or symptomatic CHF with concomitant decline in LVEF. The cumulative incidence of cardiac events at 7 years was 4% in the trastuzumab arm and 1.3% in the non-trastuzumab arm, a 2.7% absolute difference. Notably, only 2 of the 37 cardiac events in the trastuzumab arm occurred beyond 2 years follow-up. Overall, LVEF recovered to greater than or equal to 50% in over half of patients. Only 1 cardiac death has been observed to date in either arm of the trial. The authors also report the outcomes of 69 patients who discontinued trastuzumab due to declines in LVEF not associated with any symptoms of cardiac dysfunction, and who had LVEF evaluation greater than 6 months after trastuzumab discontinuation. Reassuringly, in 54 of 69, that is 78% of patients, LVEF recovered to at least 50%. The authors also developed a cardiac risk score, including age and baseline LVEF, for prediction of the absolute risk of CHF in individual patients. Using the equation provided in their paper, we calculated cardiac risk scores for a series of hypothetical patients. This is shown in Table 1 of our editorial. For example, plotting the cardiac risk score against the modeled CHF risk curve in the Ramond publications suggests that a 45-year-old woman with an LVEF of 65% would have a 2.3% predicted risk of a cardiac event, whereas a 65-year-old woman with an LVEF of 55% has a 13.1% predicted risk. The authors should be commended for attempting to develop a clinically useful risk model, although there are a number of limitations to consider. First, the model was based on a relatively small number of actual events. While the identified risk factors are similar to those reported in N9831, without validation in an independent data set, it is difficult to be certain of the absolute risks predicted for an individual patient. Second, as illustrated in Table 1 of our editorial, the calculated cardiac risk score, and hence estimated cardiac risk, is highly dependent on the baseline LVEF. Because many centers routinely perform echocardiograms, one can appropriately ask if the inter-observer variability in assessment of LVEF would skew the model. In one study, baseline inter-reader variation in LVEF was reported as plus-minus 14%, well within the range that could affect the predicted risk of cardiac event according to the B-31 cardiac risk score. Cardiac imaging by MUGA, as chosen by the B-31 investigators, may offer slightly improved precision over echocardiogram, but involves radiation exposure and offers less comprehensive evaluation of cardiac function. At this time, we would consider the individual risks calculated on the basis of this model as crude estimates at best. This is critical because it is the absolute risk of toxicities balanced against the absolute risk of benefit that forms the basis of treatment recommendations. Third, the eligibility criteria for the trials limited the patient population to one that may be different from that seen in clinical practice. 6% of patients never proceeded to trastuzumab due to cardiac toxicity related to AC, and were therefore not included in the construction of the model for trastuzumab-related cardiac events. Finally, although not a direct limitation of the model, it is important to recognize that cardiac toxicity is only one of many potential toxicities associated with chemotherapy. Both TCH and ACTH can be associated with fatigue, nausea, myelosuppression, febrile neutropenia, peripheral neuropathy, alopecia, and other unwanted side effects. Most patients recover from short-term toxicities, but a substantial minority continue to experience persistent fatigue, neuropathy, and cognitive symptoms even many years out from treatment. To understand the clinical dilemmas in applying this model to a typical clinical practice, it is instructive to look within the California Cancer Registry, a population-based registry including over 20,000 incident cases of HER2-positive breast cancer diagnosed between 2000 and 2010. For young patients with high-risk HER2-positive disease and normal baseline LVEF, we believe that the standard of care remains ACTH. However, we recognize that trade-offs between efficacy and toxicity become more nuanced in patients with so-called low-risk HER2-positive breast cancer and in older patients of any stage. Notably, stage 1 node-negative patients comprise 27% of patients presenting with HER2-positive breast cancer in the California Cancer Registry, a not insignificant patient population. This is from Vincent Caggiano and Carol Paris, Personal Communication, June 2012. And although many consider HER2-positive breast cancer a disease of younger women, approximately 40% of all patients with HER2-positive breast cancer are greater than or equal to 60 years of age at the time of diagnosis. 28% of patients ages 50 to 59, 20% of patients aged 60 to 69, 19% age greater than 70. Yet in B-31, only 15% of patients were greater than or equal to 60 years of age at the time of study entry. Thus, although the B-31 model identified age as a risk factor for cardiac toxicity, this was based on a relatively small number of older patients included in the trial, and only those patients who fulfilled all other eligibility criteria. It is also likely that the frequency and severity of other toxicities in older patients are substantially different than those reported in the adjuvant trials. While it is not unreasonable to avoid anthracyclines in older individuals, particularly those with low normal baseline LVEF and/or those with node-negative disease, there are very limited data describing the tolerability of TCH in this patient population, the likelihood of completing the full 6 cycles of cytotoxic chemotherapy, or the effect on functional outcomes and recovery following chemotherapy. How do we move forward from here? First, we believe it is critical to continue to develop improved predictive markers for toxicity. Circulating cardiac troponins, which reflect subclinical cardiac damage, have been identified as predictors of cardiac dysfunction after high-dose chemotherapy, but data supporting troponins or other serologic markers as predictive biomarkers of cardiac dysfunction with trastuzumab have been mixed. Sophisticated cardiac imaging may also identify patients at risk. Recent reports suggest echocardiographic strain imaging might predict cardiac dysfunction as early as 3 months into treatment. Pharmacogenetic markers have been employed in limited settings and have been informative in selected cases, such as the risk of neurotoxicity with taxanes. Similarly, single nucleotide polymorphisms may correlate with the development of anthracycline-mediated cardiac toxicity. An evaluation of the predictive capacity of SNPs for cardiac dysfunction with trastuzumab is needed. It is hoped that use of novel predictive markers, including circulating biomarkers, novel imaging, and genomics, could enhance and personalize risk stratification for a woman with HER2-positive breast cancer, and/or identify individuals who might benefit from a cardioprotective intervention. Ultimately, cross-disciplinary collaboration between oncology and cardiology investigators is needed to identify the best strategies to predict and treat cardiac toxicity with cancer therapies. Second, we need to further expand research beyond the walls of traditional clinical trials in order to capture real-life outcomes in large populations of patients more representative of clinical practice. This is the case with respect to uncommon toxicities, such as cardiac toxicity, where the models derived from the clinical trials will invariably suffer from the limitations of patient selection described above. But it also applies to more commonly experienced toxicities, especially those that may influence patient and physician choices about therapy. Using SEER Medicare data, several groups have documented an increased risk of CHF in patients over the age of 65 treated with anthracycline-based regimens in excess of that reported in clinical trials, and the frequency of some other toxicities can be described using this methodology as well. However, CHF was defined in these studies based on claims data rather than medical record review or independent cardiology adjudication, and the studies, while important, also suffer from lack of detailed information on comorbidities, performance status, baseline LVEF, or standardized cardiac follow-up. Importantly, they also do not include linked blood or tissue samples for analysis of predictors of either efficacy or toxicity. Most importantly, we should strive to develop effective therapies with fewer associated toxicities than our traditional regimens. In the HER2-positive space, this goal is more realistic than ever. In the preoperative NeoSphere trial, a subset of patients achieved a pathological complete response with a combination of trastuzumab and pertuzumab alone, without cytotoxic chemotherapy. In the TBCRC-006 trial, the combination of trastuzumab and lapatinib produced a high rate of pathologic complete response and near pathologic complete response, again without chemotherapy. Finally, there is tremendous excitement regarding TDM1, based on promising data from a randomized phase 2 study in the first-line setting compared to trastuzumab docetaxel, and clear evidence in the second-line setting of benefit relative to lapatinib capecitabine. Preliminary reports for all of these novel HER2-directed agents have suggested a low risk of cardiac toxicity. Notably, a randomized trial of paclitaxel trastuzumab versus TDM1 in patients with stage 1 HER2-positive breast cancer will be launched later this year, with the dual goals of comparing clinically relevant toxicities between the two regimens and evaluating disease-free survival in patients treated with TDM1 as their sole adjuvant chemotherapy. Sarah Tolaney, Personal Communication, June 2012. In summary, 7-year follow-up of B-31 demonstrates a striking and reassuring lack of longer-term cardiac events. Among patients who experienced a cardiac event or asymptomatic LVEF decline, LVEF recovered to greater than or equal to 50% in the majority. Prolonged follow-up is crucial to recognize additional signals of concern. As the number of survivors of early-stage HER2-positive breast cancer grows and the number of treatment options expands, identification of predisposing factors for acute and long-term toxicities is becoming increasingly important. In a time of increasing physical constraints, it is critical to recognize the value of long-term follow-up and to fund data collection and analysis even many years after initial study results have been reported. Over the longer run, we hope to see the development of highly efficacious adjuvant treatments for HER2-positive breast cancer with substantially less risk of toxicity than current standards. This concludes the JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.